Hello, my name is Tara Rick, and I'm pleased to be presenting our abstract on clinical pathology and treatment patterns of head and neck cancer in Ethiopia. I am presenting on behalf of the group, especially noting my partner, Adagna Bakadu, from the Department of Radiation Oncology at Tikran Basis Specialized Hospital in Addis Ababa. This research is the result of a partnership between multiple organizations in different countries. Worldwide, head and neck cancer accounts for more than 650,000 cases and 330,000 deaths annually, with the majority of cases reported in higher resource countries. The incidence is reported to be increasing globally. Head and neck cancer incidence in Ethiopia was estimated to be only 3,000 cases in 2020, but this was likely underreported. There are few peer-reviewed published data on head and neck cancers in Ethiopia. So the purpose of the study was to report clinical pathology and treatment patterns to serve as a foundation of data. At the time of this study, Tikran Basis Specialized Hospital was the only comprehensive cancer center in the country. The study had a retrospective cross-sectional design with simple random sampling techniques of head and neck cancers treated between 2014 and 2017 with an analysis of descriptive data. The goal sample size was calculated to be 422, and we started with the registration data of over 1,300 patients and excluded files with wrong registration, incomplete data, and used random sampling for the 422 charts that ended up being analyzed for this study. The results were as follows. The male to female ratio was 2:1. The median age was 45 years. The most common primary site of head and neck cancers was pharyngeal, followed by oral cavity and larynx. And the most common histologic type was, not surprisingly, squamous cell carcinoma. Most patients had a good performance status, despite having a third of them having some sort of comorbidity. A third of patients reported using alcohol and 17% reported smoking. This slide highlights that a majority of the cases had advanced disease at diagnosis, so stages 3 to 4, with 4 being broken up into A, B, and C. This slide highlights that only a small number of patients received concurrent chemoradiation. However, more than half received multimodality therapy as expected, with a large number of advanced cases. However, 22% did not receive any therapy, mainly as they were lost to follow-up. 2% received palliative care. Due to reduced capacity, there was a long duration between diagnosis and initiation of treatment. A third of patients waited less than 3 months. A quarter waited 3 to 6 months, whereas another quarter waited 6 to 12 months. And then 20% of patients waited over 12 months. In conclusion, this study showed that most of the patients with head and neck cancers presented at advanced stage of the disease and waited over 3 months to start treatment. Education strategies should be focused on healthcare providers and the general population in Ethiopia to increase awareness and early detection of head and neck cancers, as well as prioritize the increase in treatment capacity to reduce wait times. And further studies are important on head and neck cancers to optimize treatment outcomes in lower capacity settings. And here are our acknowledgements and reference. Thank you very much.